Thank you for the opportunity. Lee asked me a little while ago if I wanted to share some stuff. And to be honest with you, I was supposed to be speaking this weekend in Kiev, but usually I'm asked to speak for a lot longer than 45 minutes. So like Charlie said, at some point you're going to see me looking at my watch a lot. I'm trying to compress a large lecture down to about 45 minutes to 50 minutes. But I think we should be fine. This is going to be kind of a precursor or just something to whet your appetite. Lee asked me to speak at the Pankey alumni in 2021. So that's where you would see, I guess, my larger format presentation. But when I was thinking about what to show you guys, one of the presentations I was going to give at the Hinman this year, which obviously got canceled, was a lecture called Prosthodontic Protocols, which really encompasses everything throughout dentistry. We have a small laboratory in Voorhees, New Jersey, and the majority of our clients are prosthodontists, and we're doing everything from small little cases, usually single centrals, to more comprehensive cases, usually a 6 to 11, to a lot of full mouths and hybrids and such. So I call this past and present because whenever I put together a presentation, I usually dig through my old presentations to pick and choose. Like if they ask me to do an implant presentation, I'll go to my implant lecture. Single central presentations, I'll go to those lectures. And I found this slide of a case I did from a lecture from 2009 from the Chicago midwinter. And when I saw this case, I literally almost got sick to my stomach. Number one, that I used to work this way. It was incredible the amount of work we used to have to do as dental technicians to get the results that we get today in the present with things such as CADCAM and digital dentistry and 3D printing and such. But to be able to do cases like this has been the foundation for how I work presently. So to do cases like that was very difficult, and I don't regret it, but it gave me the knowledge in my brains of how to use CAD-CAM today. So that was past how we used to make cases, and what you're looking at on the screen now is how we're used to making more full mouths. It's a lot more control. We're able to scan in all the data, provisionals that have been in patients' mouths. We're able to cut back. That's the provisional that we're matching it to right there, the blue that just popped up. We can make minimal cutbacks to have a lingual protection and lingual occlusion and such. So using CAD-CAM today has really helped my laboratory to stay on the cutting edge of where we should be. It's just a tool, like I said, and I think being able to be trained how I was and use it today has really helped us. So like Charlie said, we have a small lab in Voorhees, New Jersey, and part of the reasons that I think that we've become a successful lab is because of the foundations that I was telling you about, which are rooted in the past, which are all handmade, and kind of using the foundations of today, such as CAD-CAM, to have success. So I just want to show you kind of how we made a name for ourselves and how we became a little successful. And a lot of it had to do 10 years ago by layering a lot of these feldspathic veneers. We called them additive feldspathic chips, and it was to do a lot of minimal invasive dentistry like this. Now, while CAD-CAM and modern dentistry is great, I truly, well, I know it can't mill these types of restorations. I think restorations like this still have to be done by hand. These are kind of like no prep veneers right here with these infinity margins. These are those margins with no definitive line that are varnished into the tooth. And a machine can't mill. I don't know if you see where I used clear on the outside of it and then different levels of opacity. Materials can't be milled like that. I think to have restorations like this that blend in with nature still to this day have to be done like this. And for instance, feldspathic veneers on single centrals or anterior teeth are still our go-to as a laboratory's choice of material for these types of restorations. And not only for aesthetics, I truly believe that layered feldspathic ceramic looks the best. That's a veneer on number 8, but also for marginal integrity and things like that. I believe you have the ultimate in fit and finish. So this is a huge part of our foundation, is using these types of materials. And another huge part of the foundation of success that we found as dental professionals is staying away from the past when they used to make these bulky white straight teeth. I think coming out of this crisis, this COVID crisis, you're going to have to separate yourselves a little bit as dental professionals. And a lot of people who want to be restorative or cosmetic, AACD accredited dentists, I think it's stuck in the mindset of making these straight white, almost opaque teeth. But being able to make cases like this is a multi-unit case, it's 2 crowns and 2 veneers. Being able to make them very natural and study nature has been a huge part of our success. And I believe that the public has caught on to that. So here's a 6 to 11 case, and they've become pretty much the hardest types of restorations for us to make in the lab, because every patient who does a case like this always wants them to be brighter, straight, and natural. So these 3 things are very hard, because to make 6 teeth brighter than the rest of the mouth is already going to put my hands behind my back like this, because they're going to jump out. Straight across is also going to not look so natural. So being able to make them brighter, you can see we have a higher value teeth from 6 to 11 than the lowers, but not too much where it's a harsh contrast. And then being able to play with the levels of the incisal embrasures and the translucency, this has become a huge foundation for our success. And this isn't just for layering veneers. This is also goes for the dentists that are watching when you're doing direct composite buildups. And like I just mentioned, the AACD, we do a lot of AACD accreditation cases. And I think that this stigma is dead of these like straight white picket fences, because this is a case we just did with Dr. Ryan Michelson, his final case for accreditation. And we made these 10-unit veneers, and these for me are not the typical straight white across veneers. And for the AACD to accredit him, I applaud them, because it looks like we're moving away from that past of the fake white teeth. I think another huge foundation for success for the dentists that are listening, I would say, when it comes to communicating with the lab, we don't only want to, well, I can say I don't only want to see the teeth. I'm so used to getting one-to-one macro shots of teeth and close-ups of teeth, but we really need to see the patient these days. I have to. The majority of patients or cases that we do, we see a lot of the patients in our lab. From our local dentists, they send them over. We have dentists from out of state who fly patients in, or we meet them on things like this, Skype or FaceTime, or what have you. But only seeing the teeth is not enough information for me. I think a lot of the success that we have comes from us being able to visualize the patients that you guys are sending to us. So in that foundations little area of my introduction, that was a lot of the handmade stuff that I just kind of showed you guys. Now moving that into the newer or more modern approaches to dentistry, we still have to use our knowledge that we have from the handmade days. So here's a case that's everyday cases in our lab. This is a case from Michael Klotz that my employees Sergio and Vanessa did. Vanessa's our CAD-CAM technician and Sergio's our ceramist. And having the CAD as a tool really allows us to design everything and to have a lot of precision, consistency, and repeatability. But like I said, it's only a tool. There's a myth that as dental labs, we can just hire people to press buttons and it's going to spit out teeth. This is the furthest thing from the truth. CAD-CAM technicians have to be real technicians and understand teeth. And also something that we like to do, and what I found to be best in my lab, the majority of our client base is a big lithium disilicate or EMAX client base. So we're milling a lot of our EMAX. We like to mill it in wax because that still gives us the capability as technicians who were trained in the past to use our hands to mill it and take care of a lot of the 80% upfront laborious work and still allow us that 20% on the back end to hand finish in wax. And I think that this is really the best possibility for our clients, because now it allows us to put all of our artistic and creative energy into finishing the cases instead of like that original slide of putting a full arch of pattern resin on and sectioning it and waiting days. This takes too much energy from us. So being able to focus on the back end has been a great success for us. We are also moving into a different time where we're doing a lot of iOS cases, like straight from the intraoral scanning. So here's a 28-unit case that Dr. Brandon Stapleton from Kentucky sent us. And then we can digitally design this, mill the temporaries to send him, so we're opening vertical. And to the right is a scan of the 28 units in PMMA in the mouth. And that case is cooking right now. So it's just a little preview into how we're working from our hands with these little small feldspathic veneers all the way up to not even touching an impression, straight from digital 28 units to temporary. So we really have integrated pretty well into this modern evolution of dentistry. And for me, at first I was a little against it, but now I'm really starting to embrace it because it's really I've just seen it firsthand over the last couple of years, how much it's made our doctors that we worked with lives so much easier. For instance, when we used to do a lot of these full mouths where we were raising vertical, we would do a lot of wax ups, and a lot of doctors wouldn't want matrices back from us. They said, it's too much work, make me eggshells and we'll just reline them. We always had some little issues. There's different techniques and such to like tack the shell in and then reline it, but we always had a little cant off, or maybe the vertical wasn't raised accurately. And to put in all this diagnostic work to have that happen became very frustrating. But with digital technology, it's way easier now because we can still do our full mouth wax ups as such, scan them, and then print our eggshells with palatal rest and retromolar pad rest. So we can open a vertical and only have one definitive seat for an eggshell. So things like that in the modern world of dentistry have really improved a big portion of the workflow for us. Now, I mentioned earlier that a lot of doctors and patients fly in. I set my lab up a little differently. To the right, that's Dr. Izzy Naeem. He's a dentist from Chicago who literally flew in like in February, right before all this started happening. He flew in, and his patient, himself and myself, we sat down, we did a mock-up with her, and we got to see her in the lab. For me as a dental technician, this is the ultimate. But as the owner of a laboratory, we do about 300 to 400 units a month in normal times, it would be impossible to see all these patients for me. So what we started to do, and especially since about 80% of our clients are out of state, so what we started to do was we're continuously sending these screenshots back to our doctors. A lot of the doctors on this program right now have gotten probably screenshots from their laboratory like this saying, hey doc, how you doing? Check out the final design, let me know your thoughts, show it to the patient, blah, 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 blah. I can tell you that looking at a picture like this, while it's a little informative and give you a little bit of an idea, it's also very confusing. To show a patient that is very hard. And even for some doctors and even for some technicians, you can't grasp this. So in modern times, being able to utilize modern technologies, we've been able to integrate those types of screenshots into a virtual or three-dimensional patient. So like I said, I love seeing patients, and to get the best result, I truly believe we should see the patient. I think that this is the second best thing. Why not? It's just great information, and we get to preview what we're doing in the case, and we are allowed the dentist and the patient to also preview the case. And I'll show you these cases start to finish throughout once we get into the meat of it. And before we start getting into the actual case and the workflow and how we're working through the cases, I also want to address kind of like an elephant in the room that I always hear about how back teeth don't matter and it's just the posterior. And I get this a lot as the owner of a lab, like we send you the anterior work, but the posteriors we send to the cheaper lab. And for me, it's almost like become a pet peeve because I really believe that, it's the same. I don't think that we should put care only into front teeth and not the back teeth. These are all units from Charlie Ward, who, if you weren't on when in the beginning, he introduced me, and I've been working with him for almost 10 years. And these are Charlie and I's everyday cases. None of these were made for a presentation or a lecture, but I really believe that if you want to see who a dentist is, and if you want to see who a laboratory, or if you want to see who a person is in the field of dentistry, you look at their everyday work. You don't just look at their special case. We have a lot of doctors who call us as a laboratory saying, can you make my wife's case? Can you make my front desk girl's case? This is the work that I think that you should focus on to have success moving forward, especially going into this post-corona days. Really put the emphasis onto the everyday work, because this is what makes you, in my opinion, a good clinician. So that was kind of the introduction on the foundations of success that have made me and my laboratory successful. But now I want to show you the cases start to finish, how we work through them. So I'll go through the workflows past and present, how we used to do these cases and how we're doing them and handling them today. So what I wanted to do was kind of give you guys a smorgasbord or an array of cases from small case. And because it's a lecture, I'm not going to show you guys all monolithic single unit crowns. I'll show you single centrals. It's a small case, but very difficult. Medium size or complex type anterior cases, and of course, full mouth cases. I'll show you how we used to handle them and how we're handling them today. So the single central, great, fun case to do if you know what you're doing. If not, like the case on the left, it's not so fun. It's right there, smack in the center, and it's the ultimate challenge for us as technicians, not for you as dentists. I always hear dentists saying it's the hardest case for a dentist to do. It's not the hardest case for a dentist to do. It's the hardest case for the technician to do. incredibly hard. It's the hardest case for the dentist to handle when we don't get it right, because a lot of times we don't get it right because it's incredibly hard. But it can become a very stressful event if you're working with a laboratory that doesn't know what they're doing, and or if you're a dentist that's not communicating the correct information. So the single central on the right was the first single central that I ever saw in the mouth over a decade ago at UCLA with Dr. Ed McLaren. He was the dentist involved in that. And at the time, I thought it was an amazing central and I did a great job. But looking over it in the past, I see many faults with a lot of single centrals I've done. So here's just an array of centrals that I've done with every material. The first one I did was with alumina. The second one that I showed was a PFM, as you saw, with a large porcelain margin. This is lithium disilicate. This is Emax. I believe that's Procera. This is a porcelain fused to metal. This is Emax. So I've done them throughout the years with every material and always trying to experiment how to get the right match and the right central. And when you look at a case like this, as a dentist, you might say, I don't see what's wrong with that. That looks great. That's a great single central. What I have to tell you, to be honest, if Chad Perry's on, he's a dentist I work with. I mean, we did this case about 6 times, possibly 7. Maybe if Chad's on, maybe even 8. I don't know. This case went back and forth from Texas to Jersey over and over again until we got it right. And although we got it right, everyone involved was very patient and nice. This is like anti-business. This is very bad. So although we became good with single centrals, once in a while you'll catch a bad one that will just torture you. So I just want to show you how I got to where I got with single centrals from the past and how I'm dealing with them presently. So the pictures you're looking at right now are all pictures of natural teeth that over the years I cut open, cross-polarized, took with polarizing filters. And why I was doing this at the time, these are all very old, it's an old technique in the field of dental technology, the cross-polarized picture, to see a lot of light dynamic and enamel scattering in teeth. It's a photoelastic image. And I thought I was learning about color when I was doing this 10, 11 years ago and how to layer teeth. And the thing is, I really wasn't. It's a beautiful picture, but at the end, it's really merely just art. Cutting teeth open taught me a lot. And studying natural teeth like this, unpolarized with the rainbow, taught me a lot, but it didn't teach me about color. It taught me more about histology and where to put sclerotic dentin and how dentin should be layered, but I didn't learn anything about color with this. What I learned, and for all of you who are watching, if you want to apply this to direct composite restorations, another good exercise that really taught me a lot was demineralizing natural teeth. So if I soak a natural tooth in hydrochloric acid, it essentially demineralizes the enamel off the tooth, and then it will show you exactly how the dentin should be built, whether it be in ceramic or composite, and then where the enamel should be on the overlay. So this taught me a lot how to make teeth, but it didn't teach me so much about color. I thought I was fooling myself. So Sasha Heim and I wrote an article in Quintessence's 2011 yearbook on how to take these pictures, because everyone kept asking us how to take these pictures, and it was like this big secret in dental technology. So we published the article to just put it out there. But in concluding the article, what we kind of explained to everyone is that this shouldn't be used as an educational tool for layering. It's more just art. Fast forwarding to not so long ago, Sasha, who co-wrote the article with me, really brought the polarizing filter, the one we were using to get those rainbow pictures, back into effect in dentistry. So about 6 or 7 years ago, we really started seeing a lot of polarized images coming through for shade taking. Now, I wasn't using it for color reading then. What I was using it for was to see the intrinsic effects of the mamelons. I was looking at the opalescence on the distal, and I was looking at a value. So what a polarized image does is it takes off all spectral glare. So there's no light reflection. But what it really does, and what we're using it for today, is it allows us to measure color. Because with no light reflection, you can have a true measure of color. And I'll explain to you what Sasha and his friends from the bioemulation team did in developing Elab, because that is how we're solving single centrals today. And if you're a Pankey member and you've seen Charlie's lecture, you've probably seen Charlie talk about it a lot, but I'll show you now my experience, not just the cases that Charlie and I did, but as a dental lab, our experience. So the tools you'll need are going to be a DSLR camera. You don't need Lightroom anymore, but I want to show you Elab from its infancy to where we are now. So when it first came out, you did need Lightroom. So I'll show you how that went about. You need a gray reference card. the access bracket, which I think is very important because it's a fixed bracket, whereas the other dual point brackets bend a lot. This is always fixed at a 45-degree angle, so you'll always have a consistent picture. And of course, you will need the polarized filter via dual point or ring flash. Doesn't matter to me. So here's the first case I ever did using Elab. And traditionally, if I saw a patient, I would take a shade, traditionally with a classic shade guide or a 3D master. And I would hold the shade guide up like so. What Elab proposes is you don't need this shade guide anymore. All you need is a calibrated image with the gray reference card to read color. How do we read color? I was dumping it into Lightroom. I was calibrating it. You can see up in the right-hand corner, there's a histogram. It started out as RGB. We would just convert it to LAB, and I would take my LAB reading. What do I do with that reading next? Every Mac, I don't know PC because I only use Mac, has something called the digital color meter. So if you go into your Spotlight right now and type in digital color meter, this app will come up. All of you guys who have a Mac have it. You probably don't even know you have it. But what a digital color meter does is whatever you hover over, it will read the color of that object that you're hovering over, and it will give you an LAB value. So when it first was designed, Elab system, there was charts with LAB values and their corresponding classic shade guide. So I would read the color, go to the chart, and then layer my crown with those shade, with that shade. Here's the beauty of Elab and what really like blew my mind. I would then take a picture of the crown I made based off of that formulation, take a picture of the crown on the model, calibrate it, cut it out, and do a digital try-in. So essentially, like I said earlier, about 80% of our clients are from out of state. I'm trying in crowns now digitally. So I'm very fortunate that a lot of local doctors will send patients over, but as dental technicians, we don't work dentist hours. Sometimes at 3 in the morning, if I'm feeling creative, I might want to do a try-in, and now I can digitally try in cases in my laboratory. But to take it one step further, it's giving me way more information. What used to be very frustrating was we would get a single central back, and it might say too much yellow, it's a little high value. These are very like broad statements. We don't know what too much is or too high is. But by being able to measure my crown and then measure the natural tooth, we now can analytically see an exact number of yellow that we need to add, or an exact number of red to add. So this is a game changer, because a single central, which essentially, like I said, we did it in the past, was based off of art or creativity or talent, which is never so good for business, is now based off of science and math. So that's the first single central I ever did with Elab. The tissue is beat up. Obviously, it's just a try-in our lab. But it was not bad for me by not using a shade guide. So then once you get excited on something, you're just getting deeper and deeper. So now I'm taking digital color meters of every single central that comes in. Again, we're doing a digital try-in. For me, the heart of this system is this digital try-in. We're comparing our crown to our natural tooth. And then we're doing something called a Delta E, which is an app that compares the numbers from the natural tooth to the crown, and it spits out a calculation to see how far off you are. So it's giving you an average, it's giving you a Delta E. And then we know more or less if our crown's gonna go in before we send it out of the lab. So this is just game changer for us. So here's first try single central, non-polarized light to see the glare and the reflections, to see what kind of match we had. So a third case, we could take more readings than just one. We took 3 readings here: cervical, middle, third, and incisal. Again, taking the reading and getting a match like this. Not a perfect match, well, measuring it in the mouth like always. So now we're doing measurements, which is very good. And here's the result on number 8 from using Elab system. So that was the original form of Elab. After that, it upgraded to an app. And what we would do is we would still need the original picture. I would still calibrate it in Lightroom, and I would always want an abutment picture, and I'll show you the reason why. This is the app right here. Before, they had charts where we had to go to the charts to see what ceramic to use. On the app, what you would do is you would hover over the tooth you want measured, and you'd lock it in, And then that little box would come up right there. And if you can see it, I chose a ceramic I want to use, GC initial Lissy. I chose the abutment color, ND1, and then it literally gives me a formula. 2 scoops of Dentin A1, 6 portions of E17, 2 portions E21. I'd mix that up, and I'd go ahead and fire that, and then I would do my digital try-in. Why it's important to have the abutment color is because I'm making that color on my model. I'm using translucent material, so if I did a try-in like the picture on the right, with a stone dye underneath, white or brown, whatever color, gray, whatever color stone you use, that's gonna infiltrate the crown and throw off my digital try-in. So I want to have a model that's representative of what's in the mouth. In order for me to do a digital try-in in my laboratory, I need to have the same data of what's in the mouth. So once that's tried in, we then can bring it home. Here it is in the mouth. Again, taking measurements to compare. Even though we have a success and the case is good, we want to know how close we're getting. We always want to improve with our numbers. And now we've moved into a new generation, which just came out, I think last October. This is Elab Prime. So this is a very cool, this is Elab, and it's all based off of AI, artificial intelligence. This is their landing page, and these are the cases that I'm working on currently, or the ones I was before this whole crap happened with the virus. And this is how this works. You would put your picture in RAW into the portal. It's a web-based portal, and it calibrates it for you. So we no longer have to calibrate. And it's using all this data. That's what's pretty cool about it. Every time we load cases in, it's collecting data, collecting data, and that's how the AI is working. So then it's going to give you 2 teeth that highlighted. I click on the tooth that we want to measure. You can see up in the corner, there's a cervical and an incisal formula that it kicks out for us. We could then take a picture. You can see I use the same composite underneath the tooth to translate that color. It will try it in for us, and it will tell us the delta E, and it will give us that whole workflow. So this has been truly amazing. And I'll tell you the main reason why. This is the case with Dr. Matt Tamada. It's because it allows not just one person in the lab to do the single central. So Sergio, a ceramist at our lab, did this case, and having tools like this has just been really amazing, because it used to be there was one person in the lab that could only do the single centrals, but now having a tool that can give the guidance, a lot more people can jump in and help out. And then here's the last case that I did before the virus hit. This is the case with Dr. Mike Minokian with Elab Prime. Again, it'll highlight the teeth, I'll measure the tooth, it'll give me my formula, and then we can take it home. So that's number 9. So that's how we solved single centrals. That tool has been really, really instrumental in our remakes and our doctors happy, I guess, being happy with us as a lab and the patients. So now we'll move into a little more comprehensive type cases. I'll show you this case real quick. This is a case with Dr. Chad Perry. This is going to be the bare minimum we would need for an anterior case. If we don't have at least this information, it can get very difficult. So we will need a smile picture, intraoral 1-to-1, definitely shade information, regular and polarized. Good abutment colors is a must. And the most important, what we will need is we will need preparations based off of some kind of formula or some kind of plan. There's nothing that gets us more frustrated than just guessing a case. So when we work like this with consistency, there's never any surprises that pop up. We always have pictures as well of the temporaries in the mouth, and also complaints or concerns about the temporaries in the interim between us getting the case and finishing the case. So the only way we can have a result like this on these crowns is by having a minimum of that information. That information is applied to every case that we do. So this is how we used to do it. This is the old school way of how we did it. That case to the left is a case that I did with Matt Carmilo in South Carolina. It's a very difficult case. And that's, I think the other lab tried it a couple times. He sent it over and he says, you know, she's obviously not so happy. And that's what was underneath. It's very challenging. But we don't panic ever. No matter what's underneath, we always do an ideal wax up. Again, whether by hand or digitally, we always put the teeth where they have to be. Then we figure it out from there. How do we figure it out? With measuring tools. So we'll always send back a bunch of matrices to our doctors, and they're going to use that as measuring tools or guides to see what we can and can't achieve. So when we put this on, we start seeing some problems start arising. Again, this is ideal contour of that matrix, and underneath is the situation. Matt's an amazing dentist. He'll load the teeth on, and then he'll just start stripping it away to see where our challenges lie. And this is a big part of being a cosmetic or a restorative dentist. I think sometimes it gets confused that it's just to make pretty teeth. A lot of the legwork comes into things like this, into really seeing the challenges that are coming up. So you can see, obviously, we have some challenges by having a cervical interproximal issue throughout the whole interproximal contact issue, because that's right in the center of that tooth. So it's no problem. Matt will then make bisacral temporaries. He'll start contouring it on tissue, let everything cook for us for the time being, and then we'll get final impressions, and then we'll be able to solve everything, but only because we waxed it up with a plan, and only because Matt was an amazing doctor by giving us the room we needed and pushing that tissue out of the way and pushing it up for us and making, I don't know if you saw on that last slide, we had like a lingual throughway for the patient to go through there for the hygiene. And this is the result that we got on that case. And I truly only believe, and there's the x-rays, you can see where that tooth is in the bridge, very challenging case. But the only way to get results like this, the only way, I'm so sorry, is if we plan. Basically, this slide says a lot to me. Is to the left is no plan, and to the right, whether you like the case or not, is fine, but that's a plan. So keep that in mind, that no matter how we do it, we have to plan to have these results. So that's how we had to do it the last two, how we used to do it the last two cases, and I'll tell you how we're doing it more and more today. This is a case we also did 2 weeks before we were shut down with Dr. Graham Forbes out of Virginia, an amazing clinician, and we did this case utilizing a digital smile design by Christian Coachman. So here's Carol's case, and it was sent over to DSD in Madrid. What we're gonna get back from them is a lot of data and a lot of information. So what we get back is, first to the left, the 3D functional pre-treatment. So what that's gonna do, it's gonna do an ideal setup, but maintaining and keeping the original setup. So you can see that there's always gonna be overlays. If it's, for instance, a Class 2, Division 2 with gargoyled laterals, they're gonna be there, but you're gonna see the new. So it gives you both. Then the second, the 3D functional post-treatment, is with digital preparations, not just to the teeth, but also to the perio area. And it takes away what it has to take away to give the ideal situation. And the third design that we're gonna get is the 3D motivational mock-up. And what that's gonna be for is some kind of STL file that we can make a matrix over to actually preview the case with the patient. And they refer to it as a motivational or an emotional mock-up, but it's really just to help the patient visualize the case. So I'll run through this real quick. We'll have iOS from the doctor. These will get sent over, and we'll start with the first design. So the first design, again, is that ideal. And in Carol's case, it was good because it was more additive. The only subtractive was really on the tissue, like you'll see, but the teeth are overlaid on, I'm sorry. You can see from there, it was more adding facial and length. And again, this is a newer, I guess, method. Graham's in Virginia. This is the 3-dimensional patient that I say that we're working with today. And we are working with things like Face Hunter pretty soon and facial scans and all that. So we're having a little more 3-dimensional patients now coming in our laboratory, which does help us. Since, like I said before, the majority of our clients are out of state. Here is the second design. And again, this is the one where they're subtracting teeth and gingiva digitally if they have to. And I'll show you that in a second of what I mean. So here's all these views. So you'll see it'll give you the ideal portions here, but here's where it'll be subtractive. You see how it's 1.23 subtractive of the gingiva on number 8, 0.7 on the lateral, 1.61 on number 6. And I'll show you that later if we can print guides off that for the periodontist. So this is giving us all kind of information, not just on what the case will look like, but what will have to be reduced in order to get this. And a ton of information, occlusal, overbite. And then lastly will be the motivational design. And this will be the STL file for Graham to put into the mouth. In this case, he also used it actually for the temporary because, like I said, there wasn't a before and after where the teeth were all over the place. Since it was mostly additive, we lucked out on this one, like I said. So we got this STL, and then Graham went ahead and mocked that up in the patient's mouth. So I'll show you a video that Graham sent me of Carol that he did with her for his motivational mock-up. So that's a case, like I said, that Dr. Graham Forbes did out of Virginia, an amazing dentist. Very grateful to be working on a lot of these cases with him. I believe these are also accreditation cases as well. But so here's the deal. With all that information, it is translated into STL files, matrices, and all kinds of guides. So here's the surgical guide that was made for them to put the tissue where it needs to be. Once the tissue is all completed up, she will go home and heal, and then she will come back for preparations. So the good news about planning for me is that it allows us to do minimally invasive dentistry. I think sometimes this term or this brand of dentistry gets mixed in with no prep veneers and things like that. For me, this is a bunch of BS. Minimally invasive dentistry is all dentistry. It's just minimally reducing the minimal amount to achieve the final outcome that you want. And the only way to do that is by prepping into the final outcome. So I really believe you're doing your patients a lot of justice by prepping into the final design in some kind of temporary material or bisacryl. In that way, you will always be conserving enamel and tooth structure. So if you're just going in and freestyling and prepping, listen, we can make anything to cover it, but I think it's a disservice. I think we have to plan. And I would say almost all the dentists that we work with prep into the mock-ups that we do. So not only do you have the prep guide based off of the mock-up, but you have a nice temporary as well that you can spot etch on since they're veneers. That's how she left with that temporary based off of the design. Then Graham, of course, tried in everything before bonding, but here's his bonding procedure and protocol. Everything's bonded in. And here is day of. The filler between 8 and 9 is a little shy, but I think she came back right when all this, Virginia opened up, thank God. Like I said, we work with dentists throughout the country, and when Virginia, Kentucky, and Texas opened up, our lab came back to life. We're in New Jersey, and I'll tell you, man, it's a war zone over here. We have, I think our doctors in Jersey just started a soft opening today, but she came back a couple weeks ago to get these pictures. So I think the case came out great. Just a short note on this as well. This is a full upper we did with Dr. Chad Perry. I think a huge part of this is not just about aesthetics and how things look, but we really should have nice integration of our teeth as well. So we really want to see our teeth that we make in our crowns, like the ones we did with Graham. When we have nice margins and nice preparations, we can have outcomes like this. So I have about 10 minutes to go through the full mouth because I really want to try to stay on schedule here. So I'm going to kind of talk a little fast, I'm sorry. But on any full mouth, how we did it in the past was obviously always waxing everything up. Today we're doing it a little more digital or printing, but we need to wax things up to see where bone should be, tissue should be, teeth should be. I have an amazing waxer, Lily Beth, at my lab, and this is her work, and it's just been a pleasure to watch her do things. Planning these cases is the ultimate because we're starting to get into a little more trauma if we don't plan correctly. So here's a full mouth that I did this year with Dr. Kenny Malamed out of Boston. And if we don't plan this correctly, with 4 implants on top and 4 implants on the bottom, and we don't plan correctly, we just have 2 hammers crushing each other with no proprioception and no periodontal ligaments. So planning is very crucial. So here's the temporaries I sent back to Kenny. Kenny then would have the patient wear these in the mouth. Once the patient wore them in after a couple months, we would then get scans of that and design all of our work based off of what's been in the mouth, tried and true. Not just a proposed design, but a working design that the patient has been working through. So then we can make our substructure in titanium to the right, correct all the angles, angulated abutments, And this is how we're doing a lot of hybrids. If you guys know Kenny Malamed, who's watching, you probably know he's not a big fan of zirconia, but he called us to start doing these cases with him only if we make titanium substructures with the zirconia superstructures on top. This is how we started doing a lot of them today. And like I said, it can drop into the mouth with no problems, totally functioning. This is a Pankey Study Club, smooth crossover in the 9, and we can really rock and roll from there. So how we started doing them more today is a little more digitally. So here's a case with Dr. Ben Ross that we did. Obviously, this patient has some dental issues, and Ben wanted to do this a little faster, and Ben really likes kind of playing with us. So we wanted to do this one fully digital. So we got this, and we did a digital wax up on this. So here's an occlusal view. We opened the vertical. This is all done on Zirconzon software. And then, like I showed you in the beginning, with the palatal rest, we printed these shell temporaries. Ben was going to go ahead and prep 28 units, and now he can reline these only one way. So we put a little hole in the palate. That's a little trick that we started doing so the doctor can see that it's down. So what he can do is load that with bisacryl, put it in, capture it. Once it's relined, he can then section it in 3 sections, upper and lower, because that's how we'll take our bite. Anteriors in, posterior bite, posteriors in, anterior bite. Now we have a full upper bite. And here's the lower, which is a little more technique sensitive, because you can see to the left, it looks like it's down, but in the middle, you have to really push it until the tissue is blanching. And that's how he'll reline that. So there's Margaret after getting the crap kicked out of her for 8 hours and 28 units prepped, but it was a really good way to solve this problem digitally. Here's another way digital has helped us out with modern big cases. This is another case of Ben Ross's out of Virginia. You know, not a horrible looking case, obvious problems. It just looks like old dentistry. It's an old case, but when you start looking at the x-rays and seeing what's going on there, a lot of problems. So Ben is a prosthodontist who really takes his time. He does all of his model work. He sends us the case with everything marked where he wants us to cut the tissues and extract everything to. We really like flat ridges for these hybrids so we can have a nice interface and so we can have good hygiene. So I'll go ahead and cut that off, and then we'll do a wax setup, process that, send it back for, again, the patient to wear the prototype. So these are provisionals after her teeth were extracted and the bone was reduced with all those guides. Here's that hybrid in the mouth. And why is that so important? Number one, it gives us the aesthetics that we're looking for. So here's the full mouth temporaries after surgery. Oh, there you go. So it'll give us the aesthetics we're looking for. Like we talked about all the natural stuff with the full mouth of temporaries. This is what we're looking for, but it gives us data. This is the data that we need for consistency in these types of cases. So I showed this case in the beginning of my presentation in pattern resin where I prepared all the teeth. This is a freaking nightmare. This is like, it takes forever. Now with a scan of the case in the mouth, it's just CADCAM to create these thimble preparations, and it makes perfect preparations, but perfect. I'll show you guys in the mouth. So this information has been crucial because it's been tried and true. So that's the framework. We milled in titanium. We anodized the teeth in gold. We anodized the pink, or the tissue portion, in pink. And then we print the teeth that are going to go on top based off of the temporaries. I'll show you the reason why. So there's the milled hybrid framework. There's the printed version of the teeth. Because we already took a passivity test to verify the model. Obviously, we wouldn't go onto the framework, but we still have to verify the framework. But now we can send back for one appointment, because the goal of doing these large cases is to condense appointments. I don't want to deal with my doctors where I'm sending back for a jig, then I'm sending back for a framework, then I'm sending back for a try-in, then I'm sending back for this. I would like to condense as much as possible. So we'll send this back for a frame try-in, and we'll also send back with 3D printed final teeth, the teeth that he can sit right over the preparations so he can work through the function and make adjustments. And then I have all the data I need. That case I put to be continued because I'm actually sending it out on Friday or Monday, finished, the lower, they'll put it in. Then we'll do the upper next. And maybe 2021 at Pankey, if you guys are gonna be there, I'll show that case, if it looks good. Here's the last case that I'll show for the presentation. I'll probably make the time good. This is a case we did with Dr. Chad Perry in Fort Worth, Texas. This patient had a lot of complaints, and when you look at it, it doesn't look so bad, but she started drawing lines for us and she was very unhappy. And I think from a dental standpoint, you see visible open margins. There's a lot of wear. There's a lot of, there's a lot going on. functionally, recession, and she just was not happy with the case. So this is what I need no matter what. And whether it's from digital, or we've been using a lot of the DFA a lot lately with this angle plane, but just some kind of like XYZ access, Facebook, earbow, whatever you want to call it. This is incredibly necessary. With 5 minutes left, I don't even want to entertain the conversations of Centric. This is a Pankey presentation, so we work a lot with Skylar Bites. We work a lot with spear guides, a lot of Coist guides. So it doesn't matter how you want to get there, but we are doing a lot of leaf gauge, a lot of deprogramming, and we are restoring a lot of our work, or the majority of our work, to Centric. So I need that information transferred to me. Then once we have that digitally, like I was showing you earlier, we can do a digital mock-up very fast. This isn't cheating, but what this is allowing us is to save time to work on the case at the end. So what we'll do is I'll have the team mill out that wax that you just saw, and then with additional wax, we can put all of our energy into hand finishing it once it's milled. So we'll mill something very fast, but then we still have the capability to hand wax on to get a very bespoke or a very tailored look, as opposed to that digital type look, which you will start seeing. That's going to be the next trend, is where a lot of teeth are going to start looking the same, because a lot of people are going to start using the same libraries. They even have libraries for technicians. So we would like to be a little different. So we still like to alter things by hand. It's also very cool because it allows us to give a lot of information to our doctors. This is how I want to take a bite. It's just a slide to explain that, what I said earlier. Posterior is in, anterior is out. So they'll load anterior with some kind of, I think they use Futar or Blue Moose, whatever you use. You'll put the anteriors in and then load the posteriors to get a full upper bite. This is also very good because now that I have this data, i.e. this file, I can then mill the provisionals. So now I can send back to Chad a model with the wax ups on there and the provisionals all interchangeable. He could then see the preparations we did. He could then caliper the provisionals. He has all this information to work with. Chad will then base his preparations off of that, load it into the patient's mouth. You can see not a lot of material at the cervical, so we're very accurate by doing that. And Chad will then let the patient sit. This patient wanted a very broad, full smile, longer teeth. And this is all to be worked out in the provisional phase. If you have to adjust stuff as a dentist in the provisional phase, that's good news. That's fine for me, because that's where it should be worked out. Occlusion, this is the full upper and lower and temporaries. This is Chad in his interim time while I'm getting models and stuff ready, working out the occlusion, making sure everything's right. He's then doing a 1 month evaluation and then a 3 month evaluation. And at 3 months, you can see on that number 9, chips. And you can also see the work Chad put into the temporaries. You can see that he shortened things and he worked with the patient and he worked out everything for me. So at that point, I have a slam dunk of a case. I can make an incisal guide table, which we do. We can make matrices. We have scans of the file. We have length, we have width, we have function, we have everything to take the case home. And here's the final case. It's, I guess, what we call a micro cutback case. Lingual occlusal, lingual protection, and just a nice incisal translucency. You saw earlier in the case, she had a lot of bruxing, or she was a clincher. So we wanted to keep a lot of that with lingual protection and occlusal protection. And there we have the final smile at the end, a nice natural smile. There we have Dr. Chad Perry on the left, patient right there, me and my wife. And I think I just made time. So I condensed that down pretty quick. There's a lot more work that we're doing at our laboratory. A good place to see where we are currently is on our Instagram page. If you want to follow us there, go ahead.